So, it is a great pleasure to be able to introduce Dr. Craig Towers talking about opiate drug use during pregnancy.
Marvelous introduction. As he had explained, I'm a specialist in obstetrics and gynecology, but I only do obstetrics. I don't do the GYN part. I've always done research, as you can tell, with the number of publications, but when I came here, was amazed at how many pregnant women I would see that were addicted to opiates. And for many years, or my whole life until I got here, I would recommend that patients not get off of opiates during pregnancy. So I'll get into that in a moment. But I want to explain how this problem blew up in this country. How we're going to fix it is not easy. Its effect on society, and then get into the pregnancy aspect and what we're doing at UT, because we are going to change the practice of care in that regard for the entire country, if not the world, and it'll all come from across the river here. So to put this into perspective, if you look at what results in death of Americans, unrelated to, say, heart disease, cancer, and those types of things, motor vehicle accidents has always been number one, 44,000. In 1999, drugs was 19,000. 8 years later, drugs had doubled and was now number two. As you can see, motor vehicle accidents stayed about the same. 2014, drugs took it over. It passed it. And in the state of Tennessee, there are more adults who die from drug overdose than from car accidents since 2013. There were 63,500 deaths in the United States from drug overdose, so it's 20,000 more than what occurs in motor vehicle accidents. So it's the number one cause of death outside of medical issues, of which 80% of that now is opiates. To give you some other statistics, and this is 8-year-old data, but at 15,000 drug overdoses in women in 2010, it worked out to about 1 in 10,000 women in the United States. There were close to 1 million emergency room visits in 2010 by women for drugs, and 80% of those women were in the childbearing age. Of those deaths, 6,600 involved opioid prescription medications. This is not heroin or stuff you're getting off the street, but 6,600 of those 15,000 deaths came from oxycodone, hydrocodone, and those types of things. In 1999, just, you know, the slight difference between that and that 10 years, it was only 1,287, so it was a 5-fold increase in that 10-year period. This one is the one that kills me. In 2010, there were enough opioid pain relievers sold to medicate, sold in the United States that could medicate every single adult with 5 milligrams of hydrocodone every 4 hours for a month. So to put that into perspective, the amount of opiates sold to the Americans in this country was enough to give every single adult in the United States 185 milligram pills. Huge number of opiates. If you look at the opiate use in the world, 80% of the opiates in the world are used in the United States, but we're only 5% of the problem of the world's population. So we have a very huge problem with opiate addiction. When we look at prescriptions, Tennessee got beat by Alabama one more time. In 2012, we had 142.8 prescriptions per 100 persons. Alabama was 142.9. I was really excited that the 2016 data, we had dropped to 107 prescriptions. We're now number 3. West Virginia's number 2. So all of the states are dropping in their usage, which is a good thing, but we still have more than 100 prescriptions per 100 people. That's a lot of prescriptions for pain medicines. And as expected, as opiate use in moms goes up, the rate of, it's gone up from 1 per 1,000 births to 5.6 per 1,000 births in 2009. Neonatal abstinence syndrome has gone up. Neonatal abstinence syndrome is where a baby goes through withdrawal after it's born. People get into semantics of words, and so it's changed to neonatal abstinence syndrome, but most people understand that as withdrawal of a newborn. The reason being is that the pediatricians technically say that if you're going to withdraw from something, you had to take it, and the fetus was not taking it. It's going through a syndrome because it's not receiving it anymore, abstinence. And so that's what, when you see the word NAS, neonatal abstinence syndrome, is just what the pediatrician people call withdrawal syndrome. The main hospital charge was $39,000 up to $53,000, and I think, actually it doesn't have it. The cost in 2017 for treating one baby with NAS is about $68,000. So if you have 1,000 babies in this state who have NAS, you're looking at $60 million just spent on those 1,000 babies. So why did this go up? And there's some people who have talked about a book, blanking on his name now, Sam Quinones. I don't know if you've ever seen this book about how opiate addiction got in the United States. And it's a true book, but it really talks about the heroin trail that came from Mexico into the United States in the 60s. That just gives you the baseline rate of opiate use. This expanse, it has nothing to do with that. This has to do with the availability of pills on the street. The federal government had issues with that. The medical profession was not managing chronic pain correctly for some reason. And so, like, even when I was in California, I had to do 12 hours of continuing medical education on how to treat chronic pain, even though pregnant women usually don't have chronic pain that we would treat. We treat them other ways. And they passed a law in 2000, it's Public Law 106-386. You can look it up, and it declared 2001 to 2010 the decade of pain. And in that response, over 3,000 pain clinics opened up in the United States, and they started passing out pain pills. How do you measure true pain? The problem with pain is I could walk into anybody's room here and go, my leg's killing me. It's just killing me. I got to have something for it. How do you know I have leg pain in my leg? There's no blood test you can do, no x-ray test you can do. You just have to look at me and go, your leg hurts. Okay, you need to treat your leg pain. That's the problem with treating pain. There's no test to prove that you actually have that problem. And then what's the checks and balances, which is what now we're backlash and trying to figure this out. And so if you look at addiction, and I've been involved in drugs and pregnancy for a long time. In California, a lot of it was cocaine, and so I have several publications on cocaine in pregnancy. Is heroin's always just kind of hovered because that was the only opiate you really could abuse. And the only way to take heroin is to put a needle in your arm. So if you talk to people and they would get into areas, do you want to take this pill? Sure, I'll take this pill. And that pill might have been LSD or PCP or any of those things. Cocaine, you want to snort this stuff or all of this, but you want to shoot this needle in your arm, they would say no. The needle was a deterrent. But when you put thousands and thousands of pills on the street and say, hey, do you want to take this pill? And they go, sure, and they take the pill and it's oxycodone. It doesn't take but 10 to 14 days to get addicted to that or get dependent on it. And pretty soon they're going, I need that pill. Do you have that pill? And if they don't have the pill, then they will go to heroin. So, I mean, again, I've told legislatures and stuff that if I could just somehow evaporate all the pills off the street, we would see heroin shoot way up, but then it would drop way back down, and we would be back to the way we were in the 70s and 80s, because there's always going to be a baseline number of people who use opiates, especially heroin. But the problem is the pills. We have too many of them on the street. And these are powerful pills. They use morphine as kind of the baseline. So 1 milligram of morphine, and then you compare it. So hydrocodone, like Loratabin, Vicodin, and those kind of things, is about 60% that strength. So 10 milligrams of hydrocodone is like 6 milligrams of morphine. But oxycodone, the big one that was the #1 abused drug, as you'll see, but now it's been switched, is 1.5 times. So 10 milligram of oxycodone, which is like Percocet or something like that, that's 15 milligrams of morphine. Very powerful. You get up into methadone, which is one of the drugs we use. Heroin is 3 to 4 times stronger than morphine. Methadone is 4 to 5 times stronger. This one is Opana, which is a terrible one that we've had in East Tennessee. It's called Opana, but it's oxymorphone. It's 7 times stronger than morphine. And I'll have women come in and say, I'm taking 30 milligrams of Opana 4 times a day. So that's 900 milligrams, 800 milligram morphine equivalents. If you took that, it would kill you. They've worked their way up to be able to tolerate that. And buprenorphine, which is Subutex, you may have heard the term Subutex and stuff, it's the other drug used like methadone to treat the opiate addiction problem, because oxymorphone, oxycodone, hydrocodone, morphine, codeine, all have very short half-lives. They only work 4 to 6 hours, whereas methadone is 24 hours and buprenorphine is 36 hours. And so it's long-acting. And so this one and this one are used to maintain people so that they don't use the drugs on the street. Now, what's resulting in death is this drug. You may have heard of things like fentanyl. And for some reason, the drugs that are on the street are tainted with fentanyl. It's 100 times stronger than morphine. And then there's another one that was in Ohio that killed 29 people about 6 months ago. Carfentanil, it's an elephant tranquilizer. It's 10,000 times stronger than morphine. So all you got to do is take a speck of that and it'll kill you. Not much. And fentanyl just needs a tiny bit of dust of that and you will overdose and die. And what happens with opiates is it stops your breathing and you stop breathing. And so that's the most of the deaths are accidental deaths from fentanyl overdose, 60% of those deaths, that they didn't know they were taking it. The person who was using it thought they were taking oxycodone and it was tainted with fentanyl and they've died. So street drugs are not pure, they're interchanged, the supply comes and goes. You know, heroin is injected and most of the drug dealers do not give you pure heroin because again, pure heroin is 4 times stronger than morphine. So patients will come in and say, I'm on a gram of heroin. It's not possible. That's 4,000 morphine milligram equivalents. They probably have 10% heroin in that white powder and the other 90% of the powder is a crushed aspirin or talcum powder or something else, and they're injecting all this odd white powdery stuff into their system. And that's the problem with heroin, or fentanyl's in it. So what is your patient taking? So anytime I see any patient who is using an illicit drug, whether they're getting it off the street or from a friend or from a neighbor or family member, or they're stealing it out of medicine cabinets, you don't know if that's been tainted or what's in it. And so we need to get them off of that and into what's called MAT, medication-assisted treatment. That's methadone or buprenorphine. Now, how did I get into the pregnancy thing? When I got into this and was in my high-risk clinic where I would see pregnant women who had diabetes or pregnant women with hypertension or those kinds of things, I was seeing a lot of women who were addicted to opiates. And I'm one of these people where I kind of get tired of hearing myself say the same thing over and over again. And so these women would come in and the first thing that they would say was, I didn't plan on getting pregnant. So that's one whole different area is family planning. But the second thing that they would say when they came out of their mouth is, I want to be off of these drugs so my baby doesn't suffer for what I'm doing. And I would say, like every other physician in the United States has said for 40 years, we don't recommend it because there's a higher rate of fetal demise and distress and poor pregnancy outcome. I got so tired of saying that over and over and over again that I said, you know what? I'm going to go to the literature and I'm going to pull the research that was put together 40 years ago that made this standard of care as to what we've been doing for the last 40 years, because the recommendation is to put them into a drug maintenance program and maintain them. So you get them off the streets drugs and you get them into methadone or you get them into buprenorphine and then you maintain them. And I'm not putting MAT down. I use it in all of my patients. You're going to hear what I do is I go one step further based on my research. But what I found was somewhat surprising in the fact that what we've been doing for 40 years was based on 2 case reports. So anybody who does any research or anything has 2 women reported in the literature as single case reports is what led to the standard of care. First one was by Rementary and Nunag in 1973, and they published a paper in a major journal called the American Journal of Obstetrics and Gynecology. We call it AJOG. And she came in pregnant at 39 weeks, full term is 40 weeks. I mean, their due date's 40 weeks. And she said, had a stillbirth, baby had died. And she said she was a heroin addict and said, I couldn't get my heroin this weekend and I went through withdrawal because I couldn't get my fix. And so he said, well, your baby died because you went through withdrawal 2 days ago. And that got published. There's many reasons why a baby can die at term. And it doesn't necessarily have to be that. One case doesn't do it. You have to look at numerous cases to see if it's a risk. But 2 years later, Fred Zuspan, a friend of mine, a good guy, he developed maternal fetal medicine along with another guy named Ted Quilligan. He was a chair at Ohio State, and he had a mom that refused to take her methadone, was in the hospital there, and he did serial amniocentesis procedures. What an amniocentesis is when a woman's pregnant, we put a needle into where the baby is, away from the baby, but we draw up some of the fluid the baby is floating in, and you can do tests on that fluid. And so he had this one woman, and he did these tests every week and was measuring the epinephrine, which is an adrenaline-type substance made by our body. He measured that level in the amniotic fluid, and he showed that it was going up as she was getting off of her methadone, and he said, that probably represents that the baby's being stressed, and so we should stop this, and because Rementeria had a case report that it was related to stillbirth, we should probably not do this. Medicine 40, 50 years ago was run by the giants. He was one of the giants, and when a giant said we shouldn't probably do anything, it just kind of became edict. And since 1975, it became the standard of care to not taper people off. So I did a study. So again, standard of care since the 70s not to do it, put them in methadone. We didn't have buprenorphine until about the last 10 years. It's always been methadone until the last 10 years. And now we have buprenorphine, which most people call Subutex. But I did a study that was published in October of 2016 for the purpose of seeing whether tapering or detoxing a woman off of opiates did result in fetal death, stillbirth, poor pregnancy outcome, and then also looked at how the women went through detox to see if that had any effect. Now, this was not a study where I put women into the various groups. I just followed them prospectively based on the group they were in, and I'll show you what those groups were. And they kind of paired themselves into 4 groups, and I looked at how they did. Group 1 was in women here who got incarcerated who are pregnant. The jails in Knox County are not allowed to give opiates to help a person withdraw. So they go through acute withdrawal in jail in Knox County. Not at the recommendation of the physician who's over the jail, it's just the laws, and those have to be changed if they're going to change. Now they treat their symptoms. If a person's going through opiate withdrawal, they have stomach pains, vomiting, diarrhea, shakiness, sweatiness. It's a terrible thing to go through. You can treat those symptoms with other medications, and that's what they would do, but they could not give them an opiate. So they were acute withdrawal. And they were mostly in prison for theft, followed by sale of drugs, and I'll explain that in a minute. Group 2 and 3 were actually at the same place. These are women who were pregnant, who wanted to get off, and they went into an inpatient program, not at UT. We do not have an inpatient program at the hospital. It's a local center here, and they would detox them medically over a period of a couple of weeks and then get them off. The reason there's 2 groups is that there's another place in town called Great Starts, which is a home that if they got the woman off the opiates, she could go into the home with her kids and be maintained in this environment with someone there helping them and doing behavioral health and trying to make sure that now that they were off, that they remained off and stayed sober and all that type of stuff. If there wasn't an open bed, it was, I'm sorry we don't have a room at Great Starts. Do your best not to withdraw, go back to your doctor, and good luck. That was the group 3. Group 4 was the patients that I had that were on Subutex or buprenorphine, and I tapered them off slowly as an outpatient and got them off. And we ended up with over 300 women. But the main purpose of my study was not whether this is how we should do it. I wanted to know if detoxing a pregnant woman resulted in stillbirth and poor pregnancy outcome. So we had 301 patients. And this shows you the groups. And my group had behavioral health, and so did the ones that got into the house, the home. And if they had behavioral health, the rate of having a baby born with neonatal abstinence syndrome or withdrawal was only 17%. These are women that even though you got them off, they still had they still got back onto opiates. The group that got patted on the head with no behavioral health and said, do the best you can, look at their failure rate, 70%. And then the jail rate doesn't count. If they were still in jail, they delivered a baby that didn't have NAS because they weren't on any opiates. But if they got released from jail, they would relapse and then they would come in and the baby would be on opiates. So if you exclude group 1, because we're not going to put these women in prison if they come in pregnant, and you take group 2 and 4, those detox that had long-term behavioral health, and you compare them to the ones where we didn't have it, highly significant difference in outcome. And we had no losses. 301 women, not a single baby was lost. and no problems related to the pregnancy. When I did that study and I perused the literature, I came up with five other studies that added up to about 340 patients, so I kind of doubled the number, and they had no losses. Since then, I've done a systematic review of the literature, and I actually found 8 more papers buried all over the place from Australia and Europe, and we now have over 1,100 cases that have been detoxed without a loss related to detoxification. There's been a second systematic review. So pretty much we've answered the question that detoxification or tapering from opiates during pregnancy does not harm the fetus, does not result in a poor pregnancy outcome. So it can be done, but the question is, should it still be done? We have to understand what people don't understand is that the stillbirth rate in our low-risk pregnant population is 4 per 1,000. It's actually lower if you have a high-risk problem. If you have a diabetic or a hypertensive patient and they get prenatal care and they're followed with watching the baby very closely with ultrasounds and monitoring the baby's heartbeat and the stuff that we do, the rate of stillbirth in that group is lower than the rate in the high-risk population. So you might say, why don't we do all that testing in the low-risk population? It comes down to money. We don't have enough money to do that intensive therapy on 4 million women who get pregnant every year in the United States. It's pretty sad, but that's the way it is. The average cost of NAS is $65,000 per baby, so 20 to 23,000 cases of NAS per year, an annual cost of $1.5 billion just on those babies. You cut this in half or cut it in 3/4, we're saving hundreds of millions of dollars without harming the fetus. So what I do at Knoxville is I do everything that's recommended, because it is still recommended that pregnant women not detox and that they be maintained. I get them off of their street drugs, because those are terrible, or illicit drugs. I get them into a maintenance program, but then I offer them the option of detoxification. And the argument that has come up now is basically the boards that still talk about not detoxing say it's not harmful to the fetus, but we don't think, once the baby's treated for its withdrawal, it's okay. I want to come to that in a minute. And if the mom were to relapse, she could overdose and die if you taper her off. So we still recommend that you maintain her, because the mom won't relapse that way. But the problem is they say there's no data to say that it's harmful to the baby, but there isn't any data to say that it's safe for the baby. They're not looking at the opposite direction. And on top of that, the literature is actually out there. It's just spread out over a period of 40 years. In 20 different medical specialties and 50 different journals, and no one's coalesced it. So I'm pulling all of those papers together, and I'm going to have a systematic review of over 100 papers to show that there are problems for these kids, and I'm going to give you some examples of those here in a minute. So the final proof is going to be what happens to the baby after birth. We know that there's a risk the mom could relapse and overdose, which would be horrible. But we have to compare that to the baby. And so what I do is I get the mom off the illicit drugs. She's in a maintenance program like recommended. She's stable. She's coming to her appointments. And then I give her the choice. I think it should be the mom's choice. And I say, here's your choice. We can taper and detox you and get you off. If we do that and you relapse and you overdose, that could kill you and that could kill the baby. And that's the terminology I use with the woman, those words. I said vice versa, if you stay on it, there's an 80% chance your baby will be born dependent, go through NAS, and a 50% chance it will have some long-term issues that may extend throughout its entire life. So the risk of staying on the drug is a risk to your baby, the risk of getting off the drug is to you. And about 80 to 85% of women choose to get off. If they choose not to get off, we maintain them. But I let the mother make the choice based on a risk-benefit, give them the choice on those options. One of the studies that I did with one of my residents, who's now one of my partners, he did a fellowship, was retrospective of 332 newborns admitted for neonatal abstinence syndrome in that time period. And we found smaller head sizes. If you take the 332 moms that were babies born with NAS compared to 332 controls, head size less than the 10th percentile, 3rd percentile, and between that was highly significantly smaller in the babies born addicted than those not. Back then, the primary drug that was being diverted on the street was oxycodone, followed by buprenorphine or Subutex. This is now completely reversed. Subutex is now the #1 diverted drug. Waldhove in Norway has done some very interesting studies. She took 14 children who were delivered of opiate-addicted women and compared them to 14 children who were born of moms who didn't use opiates. And looked at their brain size with imaging and mapped out the brain volume. And these kids were 9 to 14 years of age. So this is 9 to 14 years after they gave birth. So you have 14 babies who were born with NAS and 14 babies that were not exposed to opiates. And she showed that the babies born with NAS had smaller brain volumes at age 9 to 14. She did another study of 12 children that were in a home like we have, Great Starts, where they detoxed off and were completely off of opiates, and measured their brain volumes at 4 to 5 years of age, again compared to 12 children that were not on opiates, and the brain volumes were the same. She then goes further to say that the 14 children that were in the first study were raised in optimal environments because they all came from married middle-class families who adopted those children, compared to the 12 that were raised by their biological mother and were all low socioeconomic status. And so she argued the fact that the brain volume difference was not related to who raised them. We in Australia has this linked database study of 2,234 children born with NAS, with withdrawal, compared with a matched control of 4,300 children that did not have neonatal abstinence syndrome, and then also compared it to the full children's population. And they do this national assessment of literacy and numeracy tests in grades 3, 5, and 7. And the test scores were significantly lower for the NAS children at grade 3 compared to the controls at grade 3, as well as, that should say grade, not age, and the entire population. By the 7th grade, the NAS children scored lower than the children did in the 5th grade. So the 7th graders, and so the decline in scores was progressive. And again, they bring it back to, is this decline because of the NAS or the family upbringing or both? And then Cerny's, to finish up, did the same thing that Waldhove did. Again, MRI of the brain volumes of 16 children, and these kids were 10 to 14 years of age who were born with NAS compared to 16 controls, and again found significantly smaller brain volumes at the age of 10 to 14 if they were born with NAS 10 to 14 years earlier than controls. I just finished the largest study that will probably never be reproduced, and I'm preliminarily heard this week that it's been accepted in Pediatrics, which is the #1 pediatric journal in the world. Of 858 prospectively collected babies, 420 babies born with neonatal abstinence syndrome and 429 that were not exposed. I only included pregnancies where we knew the dates were perfectly correct based on ultrasound, and the head size of the NAS babies on average was 1 centimeter smaller than the head size of the controls. 87% of these babies were on methadone or Subutex. So what we're recommending as treatment, being the maintenance, is resulting in smaller head size. Did all kinds of fancy statistics, and I controlled these babies for opiates, benzodiazepines, which is like Valium and Xanax and Klonopin, and cocaine and amphetamines and alcohol and tobacco and marijuana, gabapentin, which is Neurontin, that's another drug that's being used on the streets. Phenergan is for nausea, and then SSRIs are antidepressant medications like Zoloft, Celexa, if you've heard of any of those drugs that anybody might be on for depression. None of those were a factor in having the smaller head, only chronic opioid use. So the future direction that I'm looking at is we need to watch these kids to see how they do as they grow up and get more data on long-term outcomes. And then I need to also look at the babies that I get off and see how many of them, what their head circumference is and whether that affects the head size and changes the outcome by getting off. NAS, the other thing about it is that most hospitals in the country don't have protocols and they're treated differently by the neonatologists. And this study that we published just basically says that if you have a neonatal intensive care unit where these babies are treated, If you standardize your treatment and all the docs follow the same protocol, it saves 5 days. And again, you have to understand that 1 day in the NICU for a baby is about $3,000. And so if you save 5 days, you save $15,000 per baby, and think of thousands of babies. This is a multi-million-dollar saving by just standardizing your treatment protocol, not preventing the problem. So before I get into this slide and cover some of the new stuff, another paper I thought I had a slide on it is that these women are put in a classification with other people as being drug addicts, and it's like, what kind of person are you? What kind of mother are you? How can you do this to your baby? All this kind of stuff. And I have the largest, pretty sure we were talking about over here, the largest opiate use disorder clinic in pregnancy in the world. The reason I can say that is because 80% of the opiates are used in the United States, and I have the largest clinic in the United States. So I'm pretty sure I have the largest one in the world. We saw over 500 patients last year alone, pregnant women with opiate addiction. 335 we managed and delivered, the others were consults. This year we're projected to be over 600, and we will manage over 400 women. I'm getting about half of those women off. That's preventing 50% of those babies from having NAS. Another third are just, their dose of maintenance is way, way down low, but they didn't quite make it off. And then there's 15% that if they don't want help, they don't want help. You can lead the horse to water, but you can't get them to drink. But I think we're doing some good stuff. But what I have learned from this program by coalescing it into a single clinic, and what I mean by that is on Tuesday afternoons, the only patients that are seen in my office are pregnant women with an opiate disorder. Just like Thursday afternoon in our office is only pregnant women with diabetes. And so we have these dedicated clinics for various medical problems. We get into the behavioral health, and sadly what I learned, at least in this area, I don't know if it's nationwide, but 70 to 80% of these women were horribly abused prior to the age of 13. Half of them were sexually abused prior to the age of 13. The other half physically abused. There's emotional abuse. The other 20 to 25%, some was recreational, some was, I mean, you wouldn't believe some of these stories, like this 16-year-old girl for her birthday party, her mother, her father, and her brother shot her up with heroin as they all shot up with heroin. I'm reading this going, really? Are you serious? That was her birthday present, being shot up with heroin. One of these stories was a girl was, her brother's friend came over and put her in the basement, and 16 boys gang raped her for 3 days straight. I mean, how does anybody recover from that? These stories are beyond horrendous. And you can see how they got into the addiction process, and they are really a victim, not some terrible woman. But then they're addicted, and when you talk to someone who's addicted, they have to be able to get their drug to prevent. Most opiate addicts are not taking the drug to get high anymore. They're just taking the drug to feel normal, to prevent withdrawal. Different than cocaine and amphetamines. Anytime a person is using cocaine and amphetamines, they're using it to get high. But it doesn't have any physical connection, and so you could stop cocaine. If you were taking it and you decided to stop it, you'd have no physical withdrawal, and there's no neonatal withdrawal. I'm not saying it's good in pregnancy. That's a whole different talk, and has other major problems in pregnancy. But when you look at this, 45% of these women, only 45% have a driver's license. 55% do not have a driver's license, and only like 18% have a car. And when you combine it together and having a car and a driver's license, it's 9%. That means 9 out of 10 of these women can't make it to their doctor's appointment unless someone drives them. And who do they have to drive them? Their boyfriend who's using drugs, who's off doing something else. I mean, it's a very, very complicated population of women who've been abused to get where they're at, and they're doing everything they can to survive. And what bothers me about buprenorphine or Subutex is that it is now the #1 diverted drug. And what I've learned from this process, and I've been talking to the state officials, is it's covered by the Medicaid system. But most of the providers of this drug do not take Medicaid because they don't get paid anything. They take cash. So these providers only deal with cash. And so what happens is I get them off the street drugs, I get them into the buprenorphine program, and I will tell you it is easier for me to get a person off of Subutex than it is to get them off of methadone. So I do like that, but it has an Achilles heel as far as I'm concerned. Because they'll come in and they've put them on 16 milligrams of Subutex. If you look at that, that's 640 morphine milligram equivalents. It's powerful stuff. And I give them the option, I get them all the way, and I say, so do you want to taper and detox? And they go, oh yes, I want to taper and detox. And I go, okay, so the way my program is I take 2 milligrams out of their daily dose every 2 weeks. So if they're on 16 milligrams a day, then they go to 14 milligrams a day for 2 weeks. Then they go to 12 milligrams a day for 2 weeks, and it's 10. What invariably all these women have told me is, well, I'm not really on 16 milligrams. I'm like, okay, how much you taking? I'm only taking 8 milligrams. Okay, good. So then I go, okay, we're going to do 8 for a couple weeks, then we're going to go to 6 and this, but then it brings me back to, what are you doing with the other 8 milligrams? And that's when they go, well, I've got them at home. What's happening is they're selling those 8 milligrams, and it's $30 a pill on the street, in order to get the $900 they pay to get the 16 milligrams for a month. And this Subutex provider is getting $900 per patient that walks in the door, cash. Well, where's this woman going to get $900? Theft, prostitution, or she's going to sell her drugs. So for them to survive, they go, yes, give me the 16. I'm going to, the 60 pills, the 16 milligrams, they're 8 milligram pills. Give me the 60 pills. I'm going to sell 30 of them, get my $900 that allows me to get what I need, because I don't have $900 cash. If we only give them 8, they got to come up with $500. Where are they going to come up with $500? They need the 16 in order to get the money to get them. We've created this system that the only way they can get their drug to do the best they can in pregnancy is to bilk the system, because these places only take, and I've been telling the state, you got to make all these Subutex places mandatory that they take the Medicaid price and that you don't charge the patient, and just give the patient what she needs instead of all this extra stuff, because now buprenorphine is the #1 drug on the street, and it's an opiate. Now naltrexone, to finish up here, is something that I've done. Again, I think I'm the only one in the world who's done this. It's been used in Australia. Naltrexone is an anti-opiate drug. It's an opiate antagonist. If you gave that drug to someone who was using heroin or oxycodone or buprenorphine, you would precipitate acute withdrawal. It's related to a drug that some people may have heard of called naloxone or Narcan, which Narcan has been given to the police departments and the fire departments to where they can give it to somebody if they come across someone they think is overdosed, because that saves their life. If you give them that, it reverses the opiate effect and may save a person's life. It produces acute withdrawal, though. If you've ever seen it, it's horrendous to watch what this person goes through, but that's better than dying. Naltrexone would do the same thing. There's been 4 studies using it in Australia. Australia has an implant, and it lasts for 6 months, and so their studies have been retrospective, meaning they've looked back and basically have just found women who happened to be pregnant who had the implant in. It wasn't given to a pregnant woman, it's just the woman got pregnant with the implant in. We don't have the implant in the United States. Vivitrol, as some people have heard of naltrexone, is a shot form of naltrexone. It lasts a month. But I've been using naltrexone, and what it does is it blocks the cravings. The other thing, I'm glad I reminded myself. The other thing you have to understand about opiates in the brain is that its function is in the same location as the center for eating, sex, some cigarettes, in the center of our brain that involves cravings. If a person is hungry, you go, I'm hungry, I need to go get a sandwich, and you go get a sandwich. If you stop smoking, what's the hardest part for someone to stop smoking? God, I really want a cigarette. It's that desire to have a cigarette. It's the same thing with opiates. The person stops it, they go, I don't want to be on this, I want to stop, but man, I really want one. Their brain pushes them that way. That's one of the hardest parts of treating opiate addiction is the cravings. Naltrexone blocks those receptors. And I've used it now. I just finished a study that I submitted to our big meeting, and hopefully it'll be accepted. Because I think it's going to revolutionize what we do, because what we do is we get them off, we put them on naltrexone, and then these women don't have any desire to use opiates. If they did use opiates, they'd get sick, and it maintains them, and these babies do very well. The bridge device, I only throw that in there as I've had about 14 women with that. That's a new FDA-approved device that helps treat withdrawals. It's a device that attaches to your ear. It works a little bit like acupuncture to a certain extent, and it stimulates the sympathetic nervous system. The sympathetic nervous system is part of our brain that kind of speeds things up, is the best way to do it, that side of it. In other words, parasympathetic part of the brain slows things down. But like if somebody came in here and shot a shotgun, we'd all jump, our heart rate would go up, our eyes would get dilated. That's the sympathetic side of things, and that's what opiate withdrawal does. It increases the speed of the intestinal tract, so you have diarrhea. It produces cramps in the stomach. It causes sweating. It causes activity. So bridge device is worn for 5 days, and it blocks the symptoms of withdrawal, because they have to be off of opiates for 7 days before they can get on naltrexone. And it's that 7-day window that sometimes is hard unless you live with them. The other concern is hepatitis C. 2/3 of these women are infected with hepatitis C, 65% of them. Huge problem. And if HIV gets into the blood system, we're going to have a massive problem. And I showed from another study that one of the big reasons for connecting hepatitis C is snorting drugs and sharing the straw. Hepatitis C is passed by blood, and if somebody puts a straw in their nose and gets a little bit of blood on it, and some lays it down and the next person takes that straw and puts it in their nose, you've put somebody else's blood into a mucous membrane, and you can get infected with HIV, hepatitis C, hepatitis B, anything like that. Like I said, I already covered transportation. A lot of these women have no teeth. They have dental problems, horrible complex social lives, no issues or discussions on family planning and whether or not they want birth control. They need to have behavioral health if you're going to do this. But in any event, we're still moving along. We're doing a lot of research on this. That's where we're at, and I do believe in I've been doing this for about 7 years. In medicine, there's this edict that says for there to be a new idea in medicine, it takes 17 years to be fully implemented on average. I'm hoping it's not 17 years. I've been doing it for 7. I'm hoping it's going to be more like 11. Hopefully in the next 3 to 4 years, this will all be done, and the protocol will be what we do here. Because it's working, and I know it works. And with that, I think we got a few minutes left for a few questions.